Recording in progress.
All right, we're live and welcome to our discussion on Dickens' A Christmas Carol. So, where would the group like to start? Particular character, scene?
Scrooge.
Scrooge? All right, so what do we think is going on with Ebenezer Scrooge?
Well, at the beginning of the movie, I feel like he gave off kind of like an antisocial personality type thing. Just didn't really have respect for anybody who worked for him, anyone around him.
And then even antisocial personality traits. We're looking at that cardinal feature of a blatant disregard for and violation of others' rights. Yes or no, is Scrooge ruling it?
Now that you say it that way, I would say...
The APA.
Oh, the APA is saying it that
You're giving me
way.
a little too much.
Okay, yeah.
Good fit, but not a perfect fit.
Yeah, I'd say not a perfect
Not a perfect fit. All right. So
I guess it's not like a right that his worker has the right to celebrate with his family. You know.
Okay.
I think it could be maybe like depression because it manifests a little differently in kind of older populations. So you might not see like you may or may not see like the tearfulness and like the depressed like kind of mood. You may come across like irritability.
And hypothetically, or not, there is evidence of conduct prior to the age of 15, which in this case there is not, which would kind of rule against antisocial personality, and even then we could turn our attention to an alternate diagnosis, broadening, I can say it, our differential. That said, even if there were evidence, hypothetically, of conduct disorder, and we thought that antisocial personality was a viable option, maybe even provisional diagnosis, the APA does require us to investigate whether or not there is another mental disorder that would better explain the symptoms, and the idea of depression still comes up, right? Because of the way depression does very characteristically present in the elderly. So that, I think, becomes the differential, even if hypothetically there's evidence of conduct prior to the age of 15.
So if there's no evidence of conduct prior to the age of 15, if somebody's like 17 years old and they start displaying symptoms that go along with the antisocial, do you need the diagnosis of conduct disorder?
Yeah,
Okay.
so let's go off track a little bit,
Yeah.
because this is important to discuss, even though it might not be applicable to Ebenezer.
Mhm.
It's still applicable to yourself
Yeah.
and your career. So a 17 or 21-year-old who not only is demonstrating that cardinal feature of a blatant disregard for and violation of others' rights, but then you look at the clinical criteria and easily rules in. Right? You only need 3 of the remaining X number of criteria. Let's say they have 5 or 6 or even 7. No doubt about it. So you discuss their prior history, even developmental history, and there is no evidence of conduct. And that's supported by collateral information. Now what? We know what it's not. It's not antisocial personality disorder.
I'd be looking for other things that might have triggered this, maybe like a trauma or some kind of other factor that might have caused this sudden change in conduct.
Actually, your evaluation is going to be very similar in that you will still continue to pursue another co-occurring illness, mental disorder, that could explain the current symptoms even when they reach clinical threshold or criteria for antisocial personality. That is true. But let's say, just hypothetically, nothing's there. And depression's not there either. We'll try to make this one as clean as possible. So this is where the clinical term, not diagnosis, but clinical term of psychopathy is often used. Right? So here we could talk about psychopathy or psychopath rather than somebody having a mental illness. That's the answer here. Just for your knowledge, sociopathy, psychopathy are often interchangeable. If you look at the literature, psychopathy is adopted, there's a consensus. Sociopathy, no. So it comes more from lay circles, even Hollywood, not necessarily something that the APA, or especially forensic psychiatry, supports in terms of a consensus opinion. That is sociopathy. So the term is psychopathy. And that's one of the clinical scenarios in which we might adopt that term. Not in play here. This is
Cool.
Good. It's good for Tiny Tim, and it's good for the Cratchits.
Yeah.
But we have more now in terms of depression. So if we're thinking that Ebenezer is afflicted with a depressive illness, a depressive disorder, what are some of the questions you want to ask him? And are there any answers provided in A Christmas Carol?
Sleep.
How's his sleep? How is his sleep?
We have like that one example where he wakes up in the middle of the night when he sees the ghost of his partner.
Yeah, I think it's fair to say his sleep is disrupted.
Yeah.
Now, again, the reasons why it's disrupted is another conversation, but he may have a primary sleep disorder, known now as a sleep-wake disorder. Nightmare disorder certainly would come in. I don't know if he's hallucinating. I don't know if he has some asynchrony with REM and non-REM periods, especially during light sleep, stage 1. If he's REMing then, he may experience that as his seeing a ghost. That's a concern. So he might be headed for a polysomnography. But then again, disrupted sleep could also be part of a depressive illness too. So it doesn't necessarily rule it out, far from it. By the way, stage 1 sleep. What in a case vignette on a shelf exam might be a buzz term that will allow you to choose stage 1 sleep as your single best diagnosis. So if one of your peers entered into stage 1 sleep, as I am, enlightening him with my incredibly energetic and enthusiastic conversation, what might he do?
Would you like those like jerks? That,
Yeah, the hypnotic jerk, right? He'll almost fall off his chair, right? Goes it on, then he usually catches himself to the delight of everybody. How funny that was. By the way, stage 2 sleep? Since we're talking about it, who brought it up? Who's to blame? Stage 2 sleep? By the way, I don't see Scrooge with any hypnotic jerk. No, I mean, again, that's normal, right? That's normal behavior at stage 1. Stage 2?
Sleep spindles and K complexes.
What are they? I'm using big words now. What are they?
I know what they look like. I don't know what they actually mean.
Sleep spindles are microarousals. So again, this is light sleep where you might wake up. K complexes can follow a sleep spindle, and if so, what does it represent? The K complexes are your brain's attempt to really filter out your immediate stimuli so as to better your chances, to increase the likelihood that you are going to resume sleep. Right? Without that filter, without that K complex, you may pay attention to stuff in your room, boom, you're up. Right? So after the K complex and the sleep spindle, you could have a run of beta, which means that you're awake and alert now. So with all the best effort of that K complex, that run of beta, you're awake. Of course, if you're back to theta, you're on the right track. You're going to roll over and hopefully get into deeper stages of REM, 3 and 4, delta wave, and then finally REM. I think that's fair game. And again, one is a microarousal, the other is your brain's attempt to ignore that microarousal. All right, back to Scrooge. So, any other supporting evidence that he's struggling with a depressive disorder?
One criteria is poor appetite, and I watched like the Disney version, and he talks about how like he doesn't want to eat anything, and then when he wakes up the next day, he's suddenly very hungry again, like the appetite seems to have returned.
Yeah. His appetite's definitely diminished. I'm not sure of his baseline,
Yeah.
right? But it's diminished. I don't know if it's diminished because he's so miserly, or whether it's due to a depressive episode. It's something to investigate.
Yeah. But when I think of like alternative diagnoses, like I do lean towards like personality type issues still, or like a narcissism or OCD only because we literally looked it up and I was like, miserly reminded me of the criteria for something, and it was one of the criteria for OCD.
Right out of the DSM is, I think, the cardinal trait of Scrooge's personality: miserly spending. Yep. So obsessive compulsive personality should be under differential, but even as it is, and it should be, we still have to rule out depression, because if we think that even his miserly spending style can be attributed to a depressive disorder, the single best diagnosis will be within the depressive disorder chapter of the DSM. Now, upon resolution of the depressive features, and we're still having to discuss these, if he continues to demonstrate a miserly spending style, and I'm not sure at the end of the movie he does, then we could still consider the personality disorder. So what other evidence in this movie suggests or supports a depressive disorder?
I think he's got some. There's the Flash Bunnies with the Ghost of Christmas Past, where he, I think, leaves his wife. Seems like he has some feelings of guilt when they show him in real time. Yeah, so he's got guilty feelings.
I mean, at some point, this movie has been remade so many times. At some point, there's going to be a film made from the time he breaks up with his fiancée to the point where we pick the film up in every other version. And we're going to see a young Ebenezer Scrooge. I don't know why nobody's thought about this yet, but we're going to see this. And when we do, I think we're going to see the onset of major depressive disorder. I think there is a clear precipitant here, and I think that he is likely to demonstrate a depressed mood, a loss of interest, and Siggy caps as a result. And then we could talk about his coping. And by talking about these coping or defense mechanisms, I think we're going to be able to see how the character of Scrooge is truly born. So if there's a depressive disorder, let's step outside of A Christmas Carol for just a second and name specific. Definitely yes.
Psychologist, sorry.
There's no, in my personal opinion, there is no better illustration or example of a depressive disorder due to a general medical condition than premenstrual dysphoric disorder. And progesterone is the culprit here, and it's at its peak 1 week prior to menses, which means that the onset of the illness is 1 week prior to menses. Okay? And this alleviates with a woman's menses, when progesterone dips and is at its lowest 1 week after the onset. Right, so it is cyclical. Right, so please be able to identify that cycle and be able to identify the hormones that are in play, and that's progesterone. This is a condition due to an underlying, in as much as one's menses is a medical condition, one's physiology, officially one's medical condition. Okay. Not in play here. This is not happening with Ebenezer Scrooge. So now we're down to either major depressive disorder or persisting depressive disorder, aka dysthymic disorder. So, any thoughts here?
This is timing more than 2 years
Yeah.
time, so I feel like this has been a long-term trend.
Yeah, not only is dysthymic disorder 2 years or more, but the individual will never have been without symptoms for 2 consecutive months. And even though we don't have the information, if we were to ask, would anybody be surprised if his behavior did not alleviate for 2 consecutive months? No way. So this may actually be dysthymic disorder or persisting depressive disorder. All right. And of course, you could have both, right? So you could have someone with established persisting depressive disorder, and in addition to that dysthymic state, have a superimposed episode of depression. You could have both. That's often referred to as a double depression. And the care for that would be to maintain the treatment that has been already provided for that pre-existing condition, the persisting depressive disorder, and then add on whatever it is, antidepressant, for example, to address the depressive symptoms that are defining of that major depressive episode. All right, so we have a working diagnosis of persisting depressive disorder. Is there any other behaviors here that might need to allow us to broaden our differential diagnosis of what ails Scrooge? One is, I think, obsessive compulsive personality is something we have to consider.
Right, Jesus.
hallucinations or dreams be consistent with mixed features of depression?
Yeah, so I don't think so. That's a tricky one, right? Yeah, so is this a subtype mixed, or is this a co-occurring condition? And if so, what's going on there? So let's go through the algorithm on what we should consider to decide how we're going to explain hallucinations. One, maybe what I just mentioned, and that is he has a double depression, and that he has a major depressive episode on top of his baseline persisting depressive disorder. And this current major depressive episode is severe with psychotic features. That is possible. Okay. What else is in our differential diagnosis to address the psychotic features?
Brief psychotic disorder?
So it could be a primary psychotic disorder, including brief psychotic disorder. That's in our differential as well.
Because of his age, should he be assessed for dementia?
Yeah, I think so. This may be part of a neurocognitive disorder. Yep. What else? Now, what's one thing that weighs against this being a major neurocognitive disorder, aka dementia?
Sudden change.
Yeah, yeah. The onset is acute, right?
Could be like a stroke then.
Yeah, which means that what would be the clinical term then that we would use to describe or explain the perceptual disturbances here?
Vascular dementia.
Could be. So again, it could be a manifestation of a pre-existing dementia. What else?
Vascular dementia?
Well, that's a consideration.
Pseudodementia?
Well, we already have depression as a working diagnosis. So for pseudodementia, which is the not so clinical term for the major depressive disorder.
Encephalopathy.
Yeah, that's what I'm concerned with, delirium or encephalopathy. Yeah. So any evidence to support this is an encephalopathy, other than the perceptual disturbances themselves. What's the dialogue he has with Morley's ghost? Well, let me take a step back. What's an encephalopathy? What is? Give me the definition of delirium.
Is it just brain failure?
Yeah, more specific. So the definition of delirium conforms to the 3 C's, right? So there are deficits in cognition. The course, which readily differentiates it from dementia, is acute in onset and fluctuating. And the cause is unlike any other cause published in the DSM, right? Because outside of that chapter, every single mental disorder that you've either seen during your clerkship or discussed in this room must be investigated as due to the effects of a substance or underlying medical condition, right? And if so, we don't diagnose depression or bipolar or schizophrenia or, quite frankly, anything else. In the case of delirium, it's the direct opposite, and that is the cause is always due to an underlying medical condition or the effects of a substance, which allows us to say that delirium actually is not a mental disorder at all. It's quite the opposite. It's a behavioral manifestation of an underlying medical condition or substance. So, given this definition, and certainly the acute onset and fluctuating course of what happens to our antagonist turn protagonist throughout the night, is there any evidence that the cause of delirium is also part of the script of A Christmas Carol, allowing us to formulate delirium perhaps as a most likely diagnosis? Well, I guess the first question is, what are the causes of delirium? We discussed this already or no? We have not? The blue team may have heard this before, so if, upon hearing the next question, the blue team recalls what we discussed, you're not allowed to talk. Right? So what is, the red team, what is your favorite Shakespearean play? There's no right answer here, by the way.
I don't remember
Good for you.
Romeo and Juliet.
Romeo and Juliet.
And blue team.
Blue team.
Maybe, I don't know, Midsummer Night's Dream.
That's one. You know,
Yeah.
I'm blue too.
Blue,
That's the same Macbeth.
Macbeth,
Yeah.
actually,
The other thing would be either Romeo and Juliet or Macbeth. Yeah.
choose one.
Honestly, Macbeth.
Good choice. Macbeth is the right answer. And the reason why Macbeth is the right answer is because the most infamous scene in that tragedy happens to be one of the living. All right, so we get a little bit of foreshadowing with Macbeth himself at that banquet table when he sees the ghost of his best friend. Right now, this is a supernatural tale. We already seen 3 witches, but if Macbeth were to present the clinical practice, there is zero chance that any of you taking call with me would attribute Macbeth's perceptual disturbance to this actually seeing a real ghost. It's not going to fly in a 5-week clinical workshop in psychiatry. Instead, what I'm going to hear from you is that he's suffering from visual hallucinations, right? And in the following scene, where Lady Macbeth, quote unquote, sleepwalks, we're reminded by a physician that actually sees Lady Macbeth sleepwalking, and the actual dialogue there is that it's actually delirium. Right? So both Macbeth and Lady Macbeth are suffering from delirium. Right? So from that context, the follow-up question then is, what causes delirium? That is, what are the underlying causes? And for the blue team, you have a handy acronym for me.
Intoxication.
Yep.
I don't know the acronym. Metabolic disturbances.
Blue team?
I actually don't remember talking about
We're talking about hyperammonia.
Yeah.
Ammonia. I can't say it.
Oh, wait, so our discussion is more case specific. Or,
Okay.
in this fictional case called Macbeth, the actual acronym is I Heart Lady Macbeth. If you remember that acronym, you remember every single etiology to consider for any patient presenting encephalopathy. Right? So don't read Macbeth. Well, read Macbeth first. But at least review that scene. And if you're interested, I'll look up my PowerPoint to give you the actual acting scene. You'll never forget delirium. All right? And then you'll never forget I Heart Lady Macbeth. And you'll never forget, number 1, immunologic. Number 2, heart. Right? So anything cardiovascular, acute MI. Arrhythmia. Lady, LP.
Oh, I didn't know that I was an infection, but I don't know.
Oh, okay, we're getting there. LP, ABG, that's the evaluate hypoxemia. Drugs, YAWS, Y-A-W-S, that's a spirochete infection. So think RPR. And if you're thinking RPR, always think 2023 HIV serology. But it's going to be packaged. Macbeth, malignancy. Ammonia, hepatic encephalopathy. CBC, right, so infection. Okay, you're thinking CBC, automatically think urinalysis as well. That's going to be packaged as well. Comprehensive metabolic panel. And C also represents ceruloplasmin, right, so a screening test for Wilson's disease. Right. B vitamin deficiency, so certainly B12 folic acid, B12 that is ordering a B12 level higher yield than folic acid. We usually order both, unfortunately. Any history of alcohol use disorder or suggested history, thiamine level 2, B1 level as well. EEG for non-convulsive status. T, thyroid, so TSH, trauma. And H, hypertensive encephalopathy, head CT or MRI. And then the final H is heavy metal poisoning. All right. It'd be great if we could just tweak that, somehow rearrange that, and make this I Heart Scrooge. I tried, didn't I? Macbeth, unfortunately, well, or fortunately for those Brit-Lit enthusiasts, will be the acronym to remember all those emails. If you check my Instagram page, there's a pickup there with the acronym for you. All right. What's going on with Scrooge, though? What is that dialogue he has with Marley's ghost? Because he tells Marley, you're nothing but a bit of undigested beef or a blot of mustard. Right? So he's actually pointing to GI pathology as the cause of his perceptual disturbances. He's telling us that his perceptual disturbances are due to an underlying medical condition, and with there being acute onset, boy, does this look like delirium. Which, of course, biopsychosocially, as well as the 3 Ps, right? So when we formulate human behavior, when we formulate abnormal human behavior, for example, delirium, we always think biopsychosocial, but we always think in accordance to what precipitates behavior. What then, I'm sorry, I always forget one. What initially predisposes to, then what precipitates behavior, and then what perpetuates behavior, right? So in terms of a precipitant, and more specifically, a psychosocial precipitant, the fact that he sees Marley's ghost at night is significant, right at sundown. Then, of course, the biological precipitant may in fact be a GI pathology. I mentioned his appetite before, that could predispose. He's dehydrated, he's malnourished. Questions? In A Christmas Carol has resulted in physicians trying to recognize then or an opportunity that, or recognizing an opportunity, what they're doing. Right? Are they making a conscious effort to deceive you as a healthcare practitioner? Differential diagnosis is twofold. One I already heard, conversion disorder. What's the other?
What used to be called Munchausen by proxy, but now factitious disorder.
Hold on to that thought.
Okay.
Hold on to that thought. The other disorder in terms of this differential is referred to as somatic symptom disorder, previously known as somatoform disorder. So somatic symptom disorder is a condition, it's a mental disorder, in which an individual presents with one or more physical complaints for which no underlying physical process can explain. When that physical complaint specifically is about voluntary motor or sensory function, we call that variant of somatic symptom disorder conversion. So the APA kind of just teases that out because of how common that particular complaint is, right? So there's your differential diagnosis. So let's start with somatic symptom disorder. Tiny Tim is ruling in. And the follow-up question is Tim's symptom or sign consistent with voluntary motor and or sensory deficit? And the answer is yes. So we change our provisional diagnosis of somatic symptom disorder to conversion disorder. Right. Now, you go into a conference room in suite 2200, you have this discussion, and you go back to the patient room to review with the patient what you think is going on, what you believe it is to, and helping explain and answer the questions why he presents the clinical practice today, and you see him doing jumping jacks and hopping on that foot that he's telling you he has no power or that leg. So you very gently close the door, come back to this room and say, you know what? I think he might be feigning illness. Now what is your differential diagnosis?
Tissues.
Right. Exactly. That's it. Yeah, that's absolutely right. It's a twofold differential now on the peripheral other side of the column. We're going to be down column B now, upon discovery of evidence that the patient is in fact feigning or misrepresenting their symptoms in some way.
And because he's a child, you also have to consider, are his parents feigning
Exactly right.
in some way?
Right. So the next step here is to determine the difference between these two conditions you just told me. Upon discovery that the individual is in fact feigning illness or misrepresenting their signs and symptoms, the clinician must ask what their motivation is, otherwise referred to as their gain. Okay, and the question you're going to ask yourself is there any evidence to support that there's an external reward that is in play here that is motivating the patient's behavior? And if the answer is yes, we're going to pull a malingering. In the absence of any external reward, we assume that there is none. Right? And that's the default is that there is no external reward, and therefore the motivation is internal or subconscious. And then, that being the case, our single best diagnosis would be factitious disorder. And factitious disorder comes in one of two variants: factitious disorder proper, and factitious imposed on another. Or I should say, let me retract that. Factitious disorder imposed on oneself versus factitious disorder imposed on another, formerly known as factitious by proxy, itself formerly known as Munchausen's by proxy. But in the absence of any external incentives, and I'm not so sure that there isn't any here because the whole darn thing resolves when this family becomes wealthy, right? and all of a sudden he walks. Right? So, but that's another discussion, because up to this point, there has been zero evidence that Tiny Tim is misrepresenting his symptoms. This remains conversion disorder. Now, conversion disorder does have the most favorable diagnosis of any of these four conditions. The poorest prognosis is factitious disorder. Think about it. It's a condition in which if an individual is making a conscious effort to deceive you for reasons that they're unaware or unconscious of, right? That's how, I mean, if you think about that for just a second, it really does paint how difficult it's going to be to treat this condition, even with rigorous psychotherapy. On the other hand, conversion confers the most favorable diagnosis, and we see that at the end of this play / book / film. He spontaneously resolves, and that does happen with conversion. It does. Polio does not respond to that. CP does not respond to that.
How do we distinguish between somatic symptom and conversion disorder?
When the somatic symptom is voluntary motor or sensory function, we're going to call that variant a somatic symptom disorder conversion disorder. It's like it's a subtype, if you will.
Okay.
But it's a common subtype, so the DSM provided its own diagnostic classification, so its own diagnostic entity. So I agree with you. You mentioned conversion about 15 minutes ago. I actually agree. I think that's the single best answer. But now we know why. Other observations? Anything else about Tiny Tim here? Any other characters? We're pretty much right up to the towards the end here. Any other characters you want to mention, comment, or have a conversation about in Dickens' A Christmas Carol? No, we're good. All right, we'll leave it here. Next week's film, we're gonna piggyback Fiddler, so we'll go with The Christmas Vacation for next Friday's next watch. This analysis, and then I'll think of and post the Seinfeld episode.
Fiddler on
What's up?
the Roof. It's Fiddler on the Roof?
No, Fiddler is the medical student elective
Oh.
next Thursday. We show a feature-length film in the East Lecture Hall. That film is Christmas Vacation, and therefore we're going to use the Christmas Vacation for this discussion next Friday. So I mean, it's just consistent with the film, and I'll think about what Seinfeld episode we'll discuss next Friday as well. Thank you.